Should we start, please?
Yes, please, Dr. Amna. Please start.
Okay. Bismillahirrahmanirrahim. Quote of the day. A good teacher is like a candle. It consumes itself to light the way for others. Assalamu alaikum, everyone. My topic of presentation today is family planning. I'm Dr. Amna Khan. I'm a PGR in MPH. Specifically, I'll be focusing on IUCDs and injectables under the kind supervision of my respectable professor, Dr. Sair Afzal. Learning outlines. IUCDs, types, advantages, disadvantages, complications, injectables, recent advances, MCQs. Learning outcomes. Colleagues will be able to describe contraceptive injectables, different types of IUCDs, advantages and disadvantages of IUCDs and injectables, usage, complications. Injectable contraceptives. First, we'll be discussing injectable contraceptives. What are the types of injectable contraceptives? So there are basically two types, progesterone only and combined. So when we say about the progesterone only, it has progestin hormone. Duration of effect is 3 months and 2 months. Type would be depomedroxyprogesterone acetate and norethindrone enanthate. Combined we have progesterone, estrogen. The duration of effect is 1 month. Examples are cyclophem and mesigina. Types of progestin only injectables. Depomedroxyprogesterone acetate, injection every 3 months, 13 weeks. Norethindrone enanthate, injection is given every 2 months, that is 8 weeks. They have similar effectiveness, safety characteristics, and eligibility criteria. Types. Combined injectable contraceptives. Medroxyprogesterone acetate is combined with estradiol cypionate. Examples are cyclophem and lunella. 25 milligram of medroxyprogesterone acetate and 25 milligram of the estradiol cypionate is combined. Norethindrone enanthate combined with estradiol valerate. For example, is mesigina and noriginone. What are the differences between the injectable contraceptives of different types, like the combined ones and the progestin ones? So the progestin only contraceptives, they only have progestin. Examples are DMPA, that is depomedroxyprogesterone acetate, and the combined one, they contain both estrogen and progesterone. Mechanism of action basically is preventing ovulation, given every 1 month, very effective at less than 1 pregnancy per 100 women. Health benefits are mostly like similar to the combined oral contraceptives that we have already discussed. So when we talk about the only progestin ones, the mechanism of action is preventing ovulation, thickness cervical mucus. Given they are given basically every 3 months, that is the depomedroxyprogesterone acetate, and the norethindrone enanthate is given every 2 months. They are very effective at less than 1 pregnancy per 100 women. Depo-Provera advantages are it works for 3 months continually, does not require daily maintenance, often stops menstruation completely. Disadvantages: women should not use Depo-Provera for more than 2 years in a row because it can cause a temporary loss of bone density. Does not protect against STDs. So what are the advantages and disadvantages of contraceptive injections? So basically, advantages are decreased menstrual bleeding, cramping, improvement with endometriosis, reduced risk of endometrial cancer, reduced risk of ovarian cancer, safe to use with blood clotting disorders, good with seizure disorders, effective for physically challenged, decreased ectopic pregnancies, breastfeeding is not compromised, private. Disadvantages are irregular bleeding, amenorrhea, hypoestrogenism, vaginal dryness, acne, hirsutism. Return to fertility may be delayed. No protection from STDs. Weight gain average of 5.4 in 1 year. In first year, bone mineral density effect. Calcium, either diet or supplement, weight beating, exercise. IUDs. So now we'll be discussing intrauterine contraceptive devices. First, let's just see the anatomy of uterus. Basically, uterus womb is pear-shaped dynamic muscular organ that is responsible for a variety of functions such as gestation, pregnancy, menstruation, labor, and delivery. The uterine delivery system works with a variety of medical and non-medical devices that perform the act of contraception in the uterus continually for a prolonged range of time. In recent times, they are mainly used for family planning. The device which is used in intrauterine drug delivery system is known as intrauterine device. So introduction, IUD stand for intrauterine device. The IUD is a small T-shaped device that is used for a method of birth control designed for insertion into a woman's uterus. 99% effective to prevent pregnancy, long term, that is 3 to 10 years. Completely reversible contraceptive methods. IUDs have attached with IUD have attached with thread or tail, which protect into the vaginal after insertion. Developmental of IUDs. Development of IUDs began in 1920s with the first generation of IUDs constructed from silk worm guard and flexible metal wire. For example, Grafenberg star and Otaring fell into disrepute because of the difficulty of insertion that need for frequent removal as a result of pain and bleeding. Subsequently, plastic IUDs of varying shapes and sizes were made available. Various inert biocompatible polymeric materials such as polyethylene and silicone elastomer were widely used to construct IUDs. The devices cause more endometrial compression and myometrial distension, leading to uterine cramps, bleeding, expulsion of IUDs. Researchers developed IUDs in the last 30 years with aim to add anti-fertility agents to more tolerated smaller devices, such as T-shaped device to enhance effectiveness, or fibrinolytic agents, such as aminocaproic acid and tranexamic acid to larger IUDs to minimize the bleeding and pain. Tatum developed a T-shaped device to conform to the better contours of uterus. This reduced side effects significantly. Zipper 1968 added contraceptive metals, and Doyle and Clue developed progestin-release IUDs. This development initiated a new era of R&D for long-term intrauterine contraception, leading to generation of recent IUDs, the medicated IUDs. Copper-bearing IUDs such as copper-7 and progesterone-releasing IUDs such as progestisert thus evolved. Now let's see what are the types of IUDs. So basically, we categorize them in 3 generations. The first one, second, and the third one. First generation IUDs, they are non-medicated or inert IUDs made up of polyethylene or other polymers, for example, loops, springs, and bows. Second generation IUDs, they include copper-containing devices, smaller and easier to fit, incorporation of copper in plastic IUDs, for example, copper-7, copper-200, etc. Third generation IUDs, T-shaped device filled with hormone like progesterone. They release slowly hormone in uterus. So there's another classification types of IUDs depending on the non-medicated one and the medicated one, also called the inert, which is basically the non-medicated, and bioactive, which is the medicated one. So examples of non-medicated: Lippes loop, safety coil, Grafenberg coil. Bioactive and medicated include copper IUDs and hormonal. So medicated IUDs, they include bioactive and hormonal. Bioactive include copper-7, copper-253 3 years, multi-load 375 5 years, copper-380 Aparaguard 10 years. And hormonal includes progestisert 1 year, levonorgestrel intrauterine device 7 years, Skyla, and Gynefix. They're basically the newer ones. Inert IUDs, they are made up of plastic, stainless steel. Examples are Grafenberg ring, Lippes loop, safety coil, and Dalton shield. So this is basically a picture of the Lippes loop, which is an inert one. Now we'll talk about the copper IUDs. So copper IUDs, basically it has a copper wire, horizontal arm, vertical stem, and strings. Copper bearing IUDs, for example, we talk about copper-7. This device uses copper wire wound to the stem. The device is made up of T-shaped polyethylene plastic. There are various grades as per the surface area of the copper wire, such as copper T30, copper T200, and copper T380. So there's cytotoxic, low concentration, spermatocidal, and spermatodepressive. Contraceptive effectiveness is more. Pregnancy rate reduced to 5%. For example, copper T200, copper T30, copper T380, copper T220. Copper wire thickness is 0.2 to 0.4 millimeter. So these are the just random pictures of the copper Ts showing copper T380, copper T220, copper T200, and the Nova as well. Now let's just see what is the anti-fertility action of copper. In high concentration, copper is cytotoxic. It enhances the spermatocidal and spermatodepressive action of an IUD, reducing motility of sperms. Cupric ion is a competitive inhibitor of progesterone and to lesser effect estrogen. Now we'll talk about hormonal releasing, for example, progestisert. Doyle and Clue first initiated the use of hormonal releasing IUDs. So Scomagna et al. In 1970 carried human testing using conventional IUD, having contraceptive steroids. A T-shaped progesterone-releasing IUD having vertical limb embedded with drug-containing silicone capsule was evolved, coated with polymer before achieving slower release. So the objectives were to enhance uterine retention, show slowly releasing steroids, for example, melangestrol acetate, formulation, suspension of progesterone, microcrystal, silicone medial fluid, ethylene vinyl acetate copolymer, EVA, release rate is 65 microgram per day for 1 year. Progestasert, it's a novel progesterone releasing IUD. So let's just talk about this. It's a device that has a solid polyethynyl vinyl acetate side arms and a hollow core. The microcrystalline progestasert is suspended in the dimension 2.5 millimeter. Dimension is 2.5 millimeter thick. Progestasert is released by diffusing through rate limiting membrane. Loaded with 38 milligram of progestasert, release rate is 65 mcg per day. Approved by US FDA in 1975 for 12 months contraceptive use. Progestasert pregnancy rate is 1.5 per 100 for pairs and 2.5 per 100 for nulliparous. Does not inhibit ovulation but interfere with implantation in endometrium and thickening of cervical mucus. Intrauterine administration was compared with oral delivery system and subcutaneous injection. Progesterone administered intrauterine shows a 45 times greater bioavailability than the other two routes. Apparently, the endometrium tissue is extremely effective for progesterone absorption. Advantages: increased effectiveness, lower menstrual blood flow, decreased dysmenorrhea. Disadvantages: need to be replaced yearly, intermenstrual bleeding, ectopic pregnancies. So this is a picture of progesterone releasing IUD. It has polyethylene ethylene vinyl acetate copolymer. So what is the anti-fertility action of progesterone releasing IUDs? So they diminish sperm transport to the cervix to the oviduct by increasing the thickness of the cervical mucus. Steroid releasing devices induce progesteronal changes that result in endometrial gland atrophy and inhibit further development of the ova. Endometrial hypermaturation is unfavorable for implantation of a blastocyst. This is associated with decidual formation induced by progesterone. Effect of estrogen-progesterone system is related to the presence of a membrane electrical potential that inhibits the ovum endometrium contact before the occurrence of implantations. Levonorgestrel releasing IUD. These carry levonorgestrel releasing device. It is an intrauterine system that has sleeves of levonorgestrel 52 milligram around its stem. It is composed of polyethylene stem covered by matrix celastin. It's 2:1. Releasing 20 mcg per day and lasting for at least 5 years. Initial fast release, then at 60% drug release, rate reduces to the 16 mcg per day. Suppress endometrium and ovulation. Also, unlike other IUDs, it may reduce the risk of PID. So this is just a picture of IUD that is Marina. It's an IUD. It has arms, knob, scale, flange, and insertion tube with plunger inside. It has slider. There are marks as well, thread cleft and threads. And this is the handle. Mode of action: prevents fertilization by damaging or killing sperm and making the mucus thick and sticky, so sperm can't get through the uterus. It also keeps endometrium from growing very thick, making lining a poor place for a fertilized egg to implant and grow. It may receive irregular menstrual bleeding and cramping. Disadvantages of levonorgestrel IUD: it may cause non-cancerous benign growths called ovarian cysts, which usually go away on their own. It can cause hormonal side effects such as breast tenderness, mood swings, headaches, and acne. When side effects do happen, they usually go after the few first months. Contraindications: pregnancy, puerperal sepsis or immediate post-septic abortion, distorted uterine cavity, congenital or acquired, unexplained vaginal bleeding, suspected genital malignancy, genital tuberculosis, active pelvic inflammatory disease. So what are the advantages of an IUD? Copper 380, an IUD Paragard is effective for at least 12 years. Copper IUD Paragard and levonorgestrel IUD Marina are the two most effective reversible methods of birth control. Only 1 out of 100 women using a copper for 12 years will become pregnant. The copper IUD prevents ectopic pregnancies. This contraceptive is very cost-effective, inexpensive over time. Use of an IUD is convenient, safe, and private. All you have to do is check for the strings each month. The Paracard IUD may be used by women who cannot use estrogen-containing birth control pills, patches, or vaginal ring. Excuse me, one second. The IUD may be inserted immediately following the delivery of a baby or immediately after an abortion. Some studies of IUDs have shown a decreased risk for uterine cancer. There is also some evidence that IUDs protect against cervical cancer. What are the disadvantages of an IUD? There may be cramping, pain, or spotting after insertion. The number of bleeding days is slightly higher than normal, and you may have somewhat increased menstrual cramping. If your bleeding pattern is bothersome to you, contact your doctor. There are medications which may give you a more acceptable pattern of bleeding and cramping. The IUD provides no protection against sexually transmitted infections. Use condom if there is any risk. There is a higher initial cost of insertion. However, after 2 years, it is the most cost-effective contraceptive method. The IUD must be inserted by a doctor, nurse practitioner, nurse midwife, or physician's assistant. A very small percentage of women are allergic to copper. A small percentage of IUDs may be expelled by a woman's body within the first few months due to an improper fit. So painful insertion, they do not avoid STDs, professional is required for insertion, and risk of ectopic pregnancies. So the newer ones are, newer IUDs are Gynafix Skyla. So Skyla is a small T body made of soft, flexible plastic. 99.5% pure silver ring differentiates Skyla on ultrasound. Instruct patients in the event of an MRI, tell their healthcare providers if they have Skyla in place. So it is arms, it is a hormone reservoir, and this is the removal threads. The Skyla inserter is a design for a single-handed loading into the insertion tube. Timing of insertion. So first we'll see about the interval and then the post more than 6 weeks of delivery. Okay, interval would be more than 6 weeks of delivery. Insert day would be 3 to 5 days of periods. Post abortal immediately after DNC. Emergency copper T 380 within 72 hours of unprotected coitus. Immediate postpartum, post placental within 10 minutes of placental delivery. Intracesarean within 48 hours of delivery. Extended postpartum anytime after 6 weeks. Complications. We'll see about the immediate complications and the remote complications. Immediate complications are cramp-like pain. For that, we have to give analgesics. Syncopal attack. So there must be like proper size of IUD. Partial or complete perforation. So there must be some faulty insertion technique. Remote complications. Pain. So pain, the proper size device should be used. Abnormal uterine bleeding, menarrhea, more duration, intermenstrual spotting. So we have to give counseling. Tranexamic acid 500 mg should be given. Not there with 11 nostril intrauterine system. 60% reduction of bleeding and 50% have amenorrhea. PID don't insert if patient has any infective vaginal discharge. Asepsis during insertion. Spontaneous expulsion 5% more than 5% more with post-abortal or postpartum insertion. Check during periods. Feeling of threads. Perforation of uterus, there is 1 in 1,000, uncommon with the withdrawal technique. So we have to do examination, X-ray with sound ultrasound and hysteroscopy. Recent updates. We'll see about the long-acting reversible contraceptives, IUDs, IUS, and implants are review. Unexpected or unintended pregnancy is a global health concern. Young women who are pregnant are refused contraception here in many nations. For women, reversible methods of contraception with long-acting methods such as intrauterine devices provide they provide more productive and then short-acting methods, including tablets and condoms. The available IUDs now provide nearly complete childbirth protection, although have few complications. Implantable contraceptives are commonly practical all around the globe. Implants are among the most effective and reliable contraceptive strategies available. The Food and Drug FDA of the United States in 1990 approved the neuroplant contraceptive. The IUDs and implants, apart from being successful contraceptives, have a variety of hormonal effects, which led to the development in the field. The insertion and removal involving a qualified individual and the aseptic setting were correlated with other small hazards for IUDs and implants. This review focuses on the complication with IUDs and implants and also focuses on the development in the field of novel IUDs approaches. So it's time for MCQs now. First one, what methods are inserted into the uterus to the vagina to prevent pregnancy? Natural methods, barrier methods, oral methods, or intrauterine methods?
D.
Yeah, it's D. The quantity of hormone released by progesterone per day is 25 microgram, 45 microgram, 65 microgram, or 90 microgram.
B.
No, it's Charlie. It's 65 microgram. Okay. If dapomedroxyprogesterone acetate is taken more than 4 weeks late, DMPA must be injected into the thigh or buttocks or deltoid 4 times a year, every 11 to 13 weeks or 3 months. So what should be done? If it is taken 4 weeks late, then give double dose of DMPA, insert intrauterine device, start oral contraceptive pill, give emergency contraceptive I pill.
B.
No, give emergency contraceptive I pill for this if you miss a dose of DMPA, or if you're late, like 4 weeks late. So at the moment, you have to give emergency contraception to the patient. Which of the following is a non-medicated IUD? Lipi's loop,
A.
copper 7, multi-load, or progesterone?
A.
Yeah, it's A. It's Lipi's loop. Which of the following is not a copper releasing IUD? Copper 7, copper T 11, or Restal 20, and multi-load 370.
C.
Yeah, that is C.
A.
No, it's C. Which of the following IUDs work by releasing hormone? A. Lipi's loop, B. Copper 7, C. Multi-load 375, or progesterone D.
D.
Yeah,
Progesterone.
that's D. So number 7, most suitable contraceptive for a lactating mother with one child is A. Combined oral contraceptive pills, progesterone only pills, C. Condom, D. Intrauterine devices.
B. Progesterone only pills.
No, it's D. It's intrauterine device. It's very safe for lactating mother. How do IUDs prevent pregnancy? A. By preventing mixing of vaginal and seminal fluids, by increasing phagocytosis of sperms, by increasing phagocytosis of eggs, by preventing the release of egg.
D. No.
B.
B.
Yes, it is B. It is by increasing the phagocytosis of sperms. How do copper ions in copper releasing IUDs prevent fertilization? A. By reducing the motility of sperms, B. By increasing the motility of the sperms, C. By causing the females to expel out the sperms, D. By causing the lysis of sperms.
D. Delta.
No, it's alpha basically. It's by reducing the motility of sperms. Number 10, what is the unique feature of hormone releasing IUDs? A. Causing lysis of sperms, B. Increasing the lysis of release of sperms by male, C. Rendering the uterus unsuitable for the fertilized egg to implant, D. Closing of vagina.
C.
Yeah, it is C. It's rendering the uterus unsuitable for the fertilized egg to implant. So here is the key. And thank you so much, everyone.
Okay, thank you very much, Dr. Amna. This is your first presentation and a very good presentation. As far as the presentation style is concerned and your presentation is concerned, you have worked very hard on it. And I think perhaps you are suffering from sore throat, so your voice was not very clear, and at certain points it is muffled. And I hope next time with the better throat, you would be able to present better. As far as the MCQs are concerned, again, a very good work has been done. However, we encourage to have 5 options. And if you go to your MCQ number 1, please.
Gigi, ma'am. Okay. Yes, ma'am.
Every MCQ should be 1 MCQ per slide. So
Okay.
there are actually 3 MCQs that are being shown on a single slide. The
Okay.
second thing is that for the first MCQ, if you read the stem, it says what methods are inserted into the uterus through the vagina to prevent pregnancy. And in the options, there is intrauterine methods. So the stem itself is having the answer. Inserted into the uterus means intrauterine. So the options are not distracting anyone, and they are actually answering the same things that are present in the stem, and the stem is giving the clues. So this MCQ is not right. Similarly, in MCQ number 2, we should avoid giving numbers, and we should not ask for recall of doses and numbers. So again, these two MCQs should be replaced by better one.
जी ma'am, okay.
Second, 5 options for each MCQ, 1 MCQ per slide. And the overall presentation is good, especially the remote complications that you have presented were good. The recent advances, again, one of a very important thing that is missing from your presentation. Please add few recent advances. You have to do the review of the literature. You have to read the research papers that have been published on the methods of contraception and how the latest things they are being incorporated, and what are the recent advances, because that is one of a very important topic for your examination. Overall, it is a good presentation, and as far as it's your first presentation, so we applaud your efforts and looking forward to more presentations from our Masters in Public Health students. Thank you very much, and Allah Hafiz.
Thank you ma'am.